It says that it is not turned on. The share. Oh, okay. Thank you for the kind introduction, and it's always a pleasure to be part of this great educational platform. And I truly appreciate everybody, including Dr. Kavita and Dr. Ishwar, for inviting me. Today, we are going to look at some of the ways by which we can characterize the liver masses based on CT and MRI characteristics. And we'll try to see if we can do a better job at characterization of a wide spectrum of primary liver tumors. So I'll not be dealing much about the metastatic disease, which is by far the most common tumor of the liver, but we'll try to see some examples as well. As we see here, that the 1971 was a great year in that the first CT images were generated in 1971 by Sir Godfrey Hounsfield. And it's interesting that it took almost 30 minutes to get one slice of the brain, and it took almost another 2.5 hours of post-processing. So by the time Dr. Ambrose, the radiologist, saw the images, it was 2 days later. So around the same time, for a comparison, the Gillette blade company came up with the so-called twin blade shaving system, which was considered a revolutionary idea. And it was not until 1998 that they came up with a triple blade system. And by the time, we had already seen a whole range of generations of CT scanners, and we were about to embark on the multi-detector CT. We already had the helical CT. And by the time, I think now they have the 4-blade shaving system. And now we are in the era of, we are beyond multi-detector CT, dual energy scanners, multi-energy scanners, and now photon counting CT technology. So if you just compare the so-called technological advances in two fields, we can see that we have made exponential progress in terms of CT technology. Now, with the latest CT scanners, we are able to do multiple scans in a very quick time. We can do very thin, high resolution images. We have excellent spatial resolution. We can do multiplanar reconstruction, and basically, we can image various organs in a much better way, so that we can do a better job at localizing the disease, detection of the disease, as well as characterization of the disease. Just an example of how we can combine with the arterial and portal venous phase images. We can obtain excellent images, both providing kind of a CT angiographic images for the surgeons to plan their surgery. And also, what is interesting about the liver is that it has a dual blood supply. The 25% of liver blood supply is by the hepatic artery, and the 75% is by the portal vein. So we can image the liver in arterial phase and portal venous phase images, so that we can take snapshot of the liver and its contents at various phases, so that we can do a better job at characterization of the tumors. Parallel to the advances in CT, we have excellent advances, both hardware and software, as well as the design of the magnets that allow us to do short breath hold, multi-phase liver imaging. And, we can obtain faster scan, even with patients who have difficulty holding breath. We have other techniques to have better images, as well as we can do dynamic post-contrast imaging. And what is interesting about the MRI is that there are two flavors of contrast agents. One is the typical extracellular agent, very similar to the iodinated contrast, but also a hepatobiliary agent that allow us to do some sequences that allow us to characterize the hepatocellular neoplasms. It's very difficult to see even some of the large tumors, particularly if we are scanning too many patients and we are looking at too many scans a day to miss even large tumors if we don't get some of the timing of the scanning right. And here is just an example of a large focal nodular hyperplasia, which can be tough to see on the portal venous phase images, but we can readily see the lobulated, uniformly hypervascular mass with central stellate scars. So we can not only improve the conspicuity of the images by obtaining the right phase of images, but also better characterize, and we can confidently diagnose this as a focal nodular hyperplasia. Here is another example. It's very difficult to see what's happening. There's some perfusion change in the periphery of the right liver. And sure enough, this was a patient with neuroendocrine metastasis. And if we don't obtain the arterial phase images where you see the lesion, one can easily miss the tumor. And here is another example of a patient with arterial phase and a slightly delayed, almost portal venous phase images. And it's very difficult to see the uniformly hypervascular right hepatic lesion on the portal venous phase images. So similar to the post-contrast images, we can either obtain fixed delays of 30 to 35 seconds for arterial phase images, around 60 to 70 seconds for portal venous phase images, and typically the equilibrium phase is 3 to 5 minutes. And once we inject some of the hepatobiliary agents, we typically obtain a 20-minute delayed images as well. So we'll see some examples as we go through the talk. As already alluded to initially, the hepatobiliary agents serve as the extracellular fluid space because they get distributed there. But the important thing is that they are selectively there is selective uptake of this contrast because of the presence of receptors for this contrast agent within the hepatocyte. So as it implies that hepatocellular neoplasms tend to retain contrast, but also it depends on the presence of whether the particular tumor has the receptors for this for this contrast. Basically, tumors such as focal nodular hyperplasia tend to retain contrast on the 20-minute delayed images, and we see the uniformly kind of hypervascular that tends to show persistent contrast enhancement or retention on delayed phase images. And as a corollary, non-hepatocellular neoplasms tend to lose contrast or appear hypointense on delayed phase images. And one can say that even hepatocellular adenomas can also behave something like a non-hepatocellular neoplasm in that. So what is happening in a simpler way, if you want to say that, most tumors will kind of take in contrast and spit it out, whereas tumors such as of FNH tend to retain or they don't spit out the contrast, whereas the hepatocellular adenomas, they don't have receptors per se. Most adenomas, I would say, but a handful of subtypes of adenomas may have the receptors. So initially, it was touted as this was the best test to distinguish focal nodular hyperplasia from adenomas, but now we see that it's much more complicated than what it is. So here are some examples of tumors that can retain and appear bright on hepatobiliary or delayed phase images. You have the classic example of focal nodular hyperplasia. You have some subtypes of adenomas, such as the beta-catenin mutated or the inflammatory adenomas that tend to have these receptors and hence appear ISO to hyperintense on the delayed phase images. And obviously, the well-differentiated hepatocellular carcinoma in the background of cirrhotic liver can also retain contrast. Now, before we go into the classic primary tumors, here is an example of biliary hamartomas or von Weinberg's complex, where we have innumerable cysts almost giving rise to the so-called starry sky appearance they may be of variable size, some of them, but most of them are quite small, and this is something not to be confused for other sinister tumors. Now, moving on to the most common mesenchymal tumor, the hemangioma, which consists of endothelium-lined blood channels and variable degrees of thrombosis, most often described as typically solitary and subcapsular hypervascular tumor. They can be multiple as well, but there are some characteristic findings of hemangiomas that allow us to confidently diagnose, with the exception of this so-called sclerosed hemangioma, which consists of thick-walled blood vessels and significant thrombosis and fibrosis, which make it somewhat more challenging to diagnose. The classic CT and MR findings and the dynamic enhancement pattern is the same. It shows peripheral nodular enhancement, and there is progressive centripetal contrast fill-in, which is pathognomic for hemangioma. What is interesting to note is that the CT density of the enhancing components mirrors that of the abdominal aorta. So if you see something, either part or whole of the mass within the liver that shows similar attenuation to that of the aorta on various phases. You see that on the arterial phase, it's bright as the aorta, and on the portal venous phase or delayed phase images, you can see similar density of the enhancing component to that of the aorta. So anything that matches the aorta, we can call it the classic hemangioma or the cavernous hemangioma. There is another variant called the anastomosing hemangioma, which I will not touch, but basically it's important to note that the cavernous hemangioma is the most common tumor that we are going to see. Famously called by the so-called mother-in-law sign, it comes early and leaves late. On MR, it's markedly hyperintense on heavily T2-weighted images, and it shows a similar enhancement pattern to that mirrors that of the abdominal aorta on various phases, and you see that classic centripetal fill-in and enhancement barring areas of thrombosis and fibrosis. It's an extremely rare, just because we are talking about mesenchymal tumor, I just wanted to show this case of a rare, typically triphasic, in that it has angioid, smooth muscle, and lipomatous components, but one can have predominantly either lipomatous or what is referred to as the epithelioid variant, which can be very difficult to diagnose prospectively. So if it's a heterogeneously enhancing mass with the prominent vasculature, with the presence of a macroscopic fat, that is something to consider. And typically, one can do a biopsy of these lesion, and the pathologists are pretty good with the classic staining of using HMB45 stain to confidently diagnose the angiomyolipoma. On the MR, the presence of macroscopic fat, it's very well elegantly demonstrated. You see that high signal intensity on in-phase images, and at out-of-phase images, you have at the periphery of the lesion, you have signal drop and the presence of the signal loss on fat suppressed T2-weighted images suggest that this is all macroscopic fat, and these are examples of so-called triphasic angiomyolipoma, or also referred to as the PICOMA, or perivascular epithelioid cell tumor. Again, some more examples of AML in that you see macroscopic fat here, and you see some prominent intratumoral vasculature, which is again another characteristic of angiomyolipoma. I was referring to the epithelioid variant, which can be malignant in a significant proportion of cases. This was a case of a malignant epithelioid angiomyolipoma, or PICOMA, malignant PICOMA, with multiple quite heterogeneously enhancing masses with prominent intratumoral vasculature. So this was a patient who initially had a small so-called fat-containing angiomyolipoma, and then subsequently developed all these non-fat containing epithelioid angiomyolipomas. Another common tumor that we typically encounter while imaging the non-cirrhotic liver is the focal nodular hyperplasia. Typically solitary, but one can have multiple focal nodular hyperplasias as well. And usually in asymptomatic, it's incidentally found, and it's usually referred to as the so-called stealth tumor because it's easily missed on the portal venous phase images, and it's seen predominantly on the arterial phase images. It has characteristic CT and MR imaging characteristics, and which we will go into some detail later. Despite, I mean, they can be small or quite large, and here is an example of a large mother of all focal nodular hyperplasias. Note that despite the large size of the mass, it shows homogeneous contrast enhancement, barring the central scar with a feeding artery that enters. And the scar shows delayed contrast enhancement, whereas the rest of the tumor may become iso-attenuating or iso-intense to the liver on portal venous phase images and beyond. And the scar is typically T2 hyperintense as opposed to the scar that we see with fibrolamellar HCC or other varieties of HCCs in which typically the scar is high T2 hypointense, and sometimes one can have T1 hyperintense scar that may show calcification as well. So the scar of focal nodular hyperplasia almost never calcifies. So if you see a scar with calcification, one should think in terms of malignancy rather than focal nodular hyperplasia. Again, we have seen some excellent examples. You see the T2 bright scar. Most of the mass is iso-intense to the liver on both T1 and T2 weighted images, so it's very difficult to see it. But we show markedly hypervascularity of this mass that sets it apart from other tumors that we see. We notice that mass like a hemangioma typically shows of this size typically shows peripheral nodular enhancement, whereas FNH shows uniform hypervascularity and shows the delayed enhancement of the scar. Another example of focal nodular hyperplasia, notice that it shows contrast retention on the hepatobiliary or delayed phase images obtained 20 minutes after contrast injection. Another example of a focal nodular hyperplasia showing reticulated appearance on delayed phase images. Moving on to the hepatocellular adenomas, even though it's a benign hepatocellular tumor, it has two risks that are concerning. One is the presence, predilection for hemorrhage or rupture due to dilated sinusoids with scanty connective tissue that predispose for hemorrhage. Another is the increased risk of malignancy, particularly in larger tumors. So the larger the adenoma, greater the chance for malignant transformation. Typically seen in young women on oral contraceptives, but patients who abuse anabolic steroids or patients with certain types of glycogen storage disorders, they are at increased risk for hepatocellular adenomas. It has characteristic findings in that one can have presence of both microscopic as well as macroscopic fat, almost, for the entirety of the tumor, as opposed to the angiomyolipoma, where it has a small to variable degrees of fat changes. And it can show kind of heterogeneous hypervascularity and also washout, very similar to that of hepatocellular carcinoma. So it can be challenging to diagnose, but particularly in a non-cirrhotic liver, in a young woman, if the imaging characteristics suggest either microscopic fat or hypervascularity and washout, one may be dealing with hepatocellular adenomas. Again, as already alluded to, they have a higher propensity for hemorrhage. So if you see a heterogeneous mass with actively bleeding either within the tumor or outside of the liver, so these patients sometimes present with hemoperitoneum and significant hemorrhage in an acute or emergency setting where they may have to embolize or do emergent surgery to take care of these patients with acute complication. Again, another example of a tumor that showed hemorrhage outside of the liver, and if you see a hypervascular heterogeneous tumor in a young woman, you are most likely be dealing with a hepatocellular adenoma. And the presence of microscopic fat on in and post phase images, it's quite characteristic for one subtype or steatotic subtype of adenomas. As opposed to the focal nodular hyperplasia that shows ISO2 hyperintensity on delayed hepatobiliary phase images. The hepatocellular adenomas typically do not have the receptors for the contrast agent, so they tend to appear as hypointense or masses which looked hypervascular on the arterial phase lose contrast on the hepatobiliary phase images. So classic finding of hepatocellular adenomas typically can be multifocal, particularly in the context of either diabetes or focal or diffuse hepatic steatosis. When you see more than 10 or most often the symptomatic adenomas, it's referred to as adenomatosis, and they may have the same complications as hemorrhage and malignant change. The recent changes and advances in genetics and imaging, as well as molecular biology of these of various tumors, have expanded our understanding of a variety of tumors, including hepatocellular adenomas. Now we know that there are basically two main imaging flavors, the steatotic and the non-steatotic adenomas that we can distinguish based on imaging characteristics. Although there is a what is referred to as the dark horse or the malignant hepatocellular adenomas that are characterized by beta-catenin mutations. So by imaging, one can differentiate between the steatotic and the non-steatotic, but it's very difficult to prospectively call something as malignant based on imaging characteristics. Here is an example of steatotic hepatocellular adenomas. Notice that there is a diffuse loss of signal on out of phase or a post phase T1 weighted images, and notice that they are typically hypervascular, and they tend to show washout on subsequent phase of images. The major factors are the oral contraceptives and a type of diabetes called the MODY type 3 diabetes. These patients are predisposed for the steatotic. Another example of a steatotic HCA that shows somewhat heterogeneous hypervascularity and washout on subsequent phase images. The steatotic ones have very low risk for bleed or hepatocellular carcinoma or the malignant change, as opposed to the inflammatory adenomas that tend to show high T2 signal intensity, and there is a border of almost very similar to that of the CSF. So you can have a very high signal intensity border surrounding a heterogeneous T2 weighted images. And you can show the similar characteristics, heterogeneous contrast enhancement, and you still see that the high T2 signal here shows delayed contrast enhancement on the post-contrast images. The major risk factors are obesity and alcohol abuse, and there's a moderate risk for hemorrhage as well as malignant change with the inflammatory adenomas. This is a complicated slide just to make sure that a variety of mediators lead to the development of the inflammatory hepatocellular adenomas. Some of these patients may have increased inflammatory markers on blood workup, and they may present with so-called inflammatory syndrome of nonspecific fever, pain, and fatigue. And so I've seen at least a handful of patients who had this so-called inflammatory syndrome who presented, who went to different doctors, ultimately were diagnosed with inflammatory adenomas. Another important causative or the etiologic factor for hepatocellular adenomas is the oral contraceptives. Particularly, it was more common with the high estrogen content of the previous generation of oral contraceptives. But with the current generation, the risk is quite low. And we see that there's a regression of this tumor following 3 month following discontinuation of oral contraceptives. It's shrinking. The hepatocellular adenomas is one of the first tumors, so-called chemical pathogenesis for development of these tumors because of the high estrogen content. And glycogen storage disorders, type 1 has increased risk for the development of multiple hepatocellular adenomas. Here is an example that is somewhat T2 intermediate signal intensity and shows hypervascularity and persistent contrast enhancement. And some of these patients may present with hemorrhage and rupture. And I've seen at least one case where we had to embolize on an emergency basis for control of hemorrhage. So these are some of the types of glycogen storage disorders that show increased tendency for development of hepatocellular adenomas. The so-called beta-catenin mutated HCA, also referred to as the malignant HCA, these are something that our pathologists can do the stains for to look for beta-catenin mutations. And any hepatocellular adenoma in a patient with anabolic steroid abuse or in man, one should potentially call it potentially malignant. And most of these tumors in the background of anabolic steroids or in men tend to be of the beta-catenin HCAs. And these are the ones that tend to show increased retention of EO-West contrast or the hepatobiliary contrast on delayed phase images. So these can be mistakenly called as focal nodular hyperplasias. So one should be aware of this caveat that not all tumors that show uptake is a focal nodular hyperplasia. Moving on to another example of an extreme example of what looked like an interesting case. So basically this came to us and we prospectively called it as diffusely infiltrative hepatocellular carcinoma. And the next, the surgeon wanted us to biopsy, and we gave the sample, and the pathology came back as fatty change or steatosis. So again, there was confusion into what's happening here in terms of is the radiologist wrong or the pathologist wrong? And usually I say that radiologists are usually correct. So this was a case of diffusely infiltrative clear cell hepatocellular carcinoma. There is microscopic fat as evidenced on the out of phase images, and including the presence of fat within the portal vein. So this was a case of tumor thrombus within the expanded portal vein in this patient with diffusely infiltrative hepatocellular carcinoma. Again, we see the same findings of tumor thrombus within the hepatic vein and the portal vein. Sometimes it can be challenging for the pathologist if they do not have the context of imaging. Once you have a classic finding of a heterogeneously enhancing mass with washout, and the pathologists know that they're dealing with a hepatocellular carcinoma, they can run the various stains, advanced stains, to ascertain that it is hepatocellular carcinoma. But in the absence of it, if it's all just microscopic fat on the specimen, it can be very challenging for them. Here is another example of a heterogeneous mass in a background of cirrhotic liver. You see that barring this high T1 signal intensity focus, rest of them lose signal on post-phase images, suggesting presence of microscopic fat. So we have already seen two examples of tumors, one benign and one malignant, that can have microscopic fat. Adenomas and hepatocellular carcinomas can have fat. And what is this high signal intensity? It's a hemorrhage within this large hepatocellular carcinoma. And the typical HCC shows kind of a heterogeneously hyper intermediate signal intensity on fat suppressed T2 weighted images, and typically do not show contrast retention. Only the small, well-differentiated hepatocellular carcinomas have a tendency to show contrast retention on hepatobiliary phase images. Another example of a tumor that is very difficult to see on the T2 weighted images, but you see that distinct loss of signal on in-phase images. It shows heterogeneous contrast enhancement and washout. One could potentially call it an adenoma, but this was a man, and this turned out to be a clear cell variant of hepatocellular carcinoma. Another example of a nodule in nodule appearance. This was how the top panel was, how it looked a few years before what we start to see the T2 hypointensity and also increased T2 signal within the same nodule. So we are seeing some changes, and we now see that there is a kind of a contrast enhancement, focal contrast enhancement on the arterial phase images. And this was the carcinoma developing within a dysplastic nodule. Another flavor of fibrolamellar, of hepatocellular carcinoma, is what is referred to as the fibrolamellar, typically non-cirrhotic, younger patients with characteristically, if you notice the scar of focal nodular hyperplasia is typically small, whereas if you see a larger scar with calcification and heterogeneous contrast enhancement, one should be thinking more in terms of fibrolamellar HCC. So the scar, the size of the scar, with or without calcification, and the overall heterogeneous contrast enhancement of this mass suggests that we are not dealing with focal nodular hyperplasia, we are dealing with a fibrolamellar carcinoma. Now, based on the improvements and advances in pathology and genetics, we now have at least 7 or 8 different subtypes of of HCCs, the so-called morphomolecular, based on morphological as well as molecular changes or genetic abnormalities. Now we have several different subtypes of HCCs, and here is one example of a fat-containing steatohepatic hepatocellular carcinoma. We can either have focal or diffuse loss of signal on in and post phase images, and shows a kind of heterogeneous contrast enhancement on post contrast images. And now there is another variant of beta-catenin mutated HCCs. And this is the one type that can progress from a hepatocellular beta-catenin mutated adenoma to beta-catenin mutated hepatocellular carcinomas. These in general tend to have a better prognosis than the other subtypes, but also depends on, typically the larger the tumor, the more heterogeneously enhancing it is. And there's another highly proliferative subtype of HCC called the macrotrabecular, which are referred to by the trabecular pattern, the thick trabeculae that they see on under the microscope. So, and these are typically heterogeneously enhancing, markedly heterogeneous tumors with significant restricted diffusion and infiltrative growth pattern, very aggressive biological behavior. And you have what is referred to as the squirrus, or the tumors with significant fibrous stroma that are referred to as the squirrus variety. And these typically have bad prognosis, and these have characteristic genetic abnormalities. And I've shown you other examples of clear cell HCCs. Typically, the presence of clear cytoplasm in more than 80% of tumor cells. It's what it's make this variant clear cell HCC based on pathological findings. Typically have microscopic fat that is evident on the in and post phase images, and these in general tend to have a better prognosis than the conventional HCC. And we have already discussed the fibrolamellar. It has characteristic heterogeneous enhancement, the so-called large scar within the tumor, and that may show calcification. And these have dense lamellar fibrosis on pathology, so that's why they are referred to as the fibrolamellar. And these have characteristic fusion abnormality involving these two genes that give rise to these classic tumor. Moving on to the other bad character, the second most malignant tumor, the primary tumor of the liver. And we again have newer classification based on the morphomolecular abnormalities. I will not go into the details provided, but we should be aware that there are three major flavors of cholangiocarcinomas that have differing risk factors, biological behavior, the way they look under the microscope is different, and these have different genetic abnormalities, and based on which some patients may receive targeted or personalized treatment for some of these subset of tumors. The common risk factors are the liver fluke, which is more common in other Southeast Asian countries, and chronic HCV is another risk factor, and the recurrent pyogenic cholangitis, as some of these examples suggest, with the segmental biliary dilatation, the presence of stones. These are calculi within the markedly dilated, chronically dilated ducts in the context of recurrent pyogenic cholangitis. And the primary sclerosing cholangitis or the ulcerative colitis in particular patients, particularly in patients with ulcerative colitis, there's a higher incidence of primary sclerosing cholangitis. And these are the patient population that have a higher risk for development of cholangiocarcinomas. So based on the anatomic location, they're referred to as either the extrahepatic or the hilar, and the intrahepatic cholangiocarcinomas, which are approximately 10% of all cholangiocarcinomas. And the intrahepatic variant is the one that has a small cell, small duct and large duct variants, which have totally different, two different diseases with different risk factors, the genetic abnormalities and different pathological characteristics. So based on imaging, one can have, kind of a mass forming cholangiocarcinomas or tumors that tend to grow along the duct, so-called periductal and the intraductal variants. The classic presence is that of either a malignant stricture with subsequent upstream ductal dilatation. One can have variety of manifestations just based on the subtypes I mentioned, either the periductal or the intraductal. You can have high signal within the dilated ducts, suggesting the presence of tumor within the dilated ducts. And another characteristic finding is that of segmental lobar atrophy in patients with cholangiocarcinoma. So particularly in the context of segmental thrombosis of the portal vein that give rise to shrinkage. So if you see dilatation without a definite mass, with or without associated lobar atrophy and subsegmental or segmental portal vein thrombosis, one should suspect cholangiocarcinoma. Another characteristic finding of cholangiocarcinoma is the so-called capsular retraction, in that because of increased desmoplasia, the desmoplastic stroma is what makes the tumors show characteristic imaging characteristics of hypovascularity as well as delayed contrast enhancement and the capsular retraction. So these are all because of the desmoplastic or fibrotic stroma in these tumors. And this is very well established on the 10-minute or the 20-minute delay that we currently obtain, in that one can have the same contrast enhancement, delayed enhancement, because of the fibrotic stroma on 10-minute delayed images. I'll not go into the details, just so that one can either, typically their metastases are multiple, and they are, for the most part, hypovascular. They can have calcifications, particularly if they are from the mucinous carcinomas of the gastrointestinal tract. They can be hypervascular. Typically, they're heterogeneously enhancing nasty-looking masses. And you typically have the hypervascular metastasis, typically in the context of either thyroid, renal cell, or neuroendocrine primaries. And this was a case of a pancreatic tail neuroendocrine tumor with with metastatic disease. So typically, we'll have a history of a prior or treated malignancy, and one can see the typically multiple tumors in the context of an existing primary. The diagnosis is straightforward, and typically the histopathological examination is essential before they start on any of the therapies. Since I've already discussed most of the primary tumors, I just wanted to show you a snapshot of one of the most common differential diagnosis, whether they are solitary or multiple on that's what we encounter most on CT and MRI. So in general, now that we have seen a wide range or wide spectrum of primary tumors, so let's assume that let's try to put them into different buckets. When we see a hemorrhagic tumor, likely be dealing with a hepatocellular adenoma in a young woman who is typically with a history of chronic or long-standing oral contraceptives, or one can potentially be dealing with a hepatocellular carcinoma, particularly in the context of cirrhosis, or occasionally you can have hemorrhagic metastasis in a patient with such as choriocarcinoma. This was an unusual case of a patient who started dropping his hematocrit, and this was an unusual hemangioma, a giant hemangioma with some dystrophic calcifications as well, and he started bleeding into the liver. So this was extremely rare case of a bleeding hemangioma. Now, we've seen some examples of so-called fat-containing liver neoplasm. So one can divide them into either macroscopic fat or microscopic fat. And here are some benign tumors with macroscopic fat. So one can have even adenomas with significant proportion of macroscopic fat, typical examples of a lipoma or angiomyolipoma. And the cystic teratomas typically are not native to the liver, but they typically are from recurrent retroperitoneal teratomas that tend to grow into the liver. What are some of the benign tumors with microscopic fat? And typically I would say just go home with the message that it's the adenomas that show typical drop on signal intensity on out-of-phase images suggesting microscopic fat, but there's an extremely rare trabecular variant of angiomyolipoma that shows the same findings. But for all practical purposes, I think anything with a microscopic fat is likely to be a hepatocellular adenoma. What are some of the fat-containing malignant liver masses? We have seen examples of microscopic and macroscopic fat. And we have seen examples of steatohepatic and clear cell variants of hepatocellular carcinomas that tend to show fat, and extremely rare liposarcoma metastasis, and sometimes even with clear cell renal cell, sometimes they can have fat on imaging. And the presence of fat sometimes can be quite puzzling and challenging, especially in this case of a nodular steatosis. We see that significant drop in signal intensity. We notice that all the blood vessels are patent. It's not a diffusely infiltrative mass as we saw on the prior images. So this was just nodular steatosis in that it looked like masses within the liver, particularly on CT. And this was demonstrated to be just nodular steatosis. And what are some of the tumors that are bright on T1? So we know that we need to exclude fat. So that's why we do the in and a post phase and also obtain fat suppressed T2 weighted images for detection of the macroscopic fat. So the fat can be bright, blood products can be bright, and occasionally melanocytic containing melanoma metastasis with melanin can also show increased signal intensity on T1 weighted images. And how about hypervascular liver neoplasms? Typically, the benign ones, the hemangiomas, the focal nodular hyperplasias, and small adenomas tend to show benign, or the benign tumors that tend to show uniform contrast enhancement. If you see heterogeneous contrast enhancement, you're likely be dealing with hepatocellular carcinoma, particularly in the context of cirrhosis. But even hemangiomas with the typical peripheral nodular enhancement and centripetal contrast fill-in and adenomas also tend to show heterogeneous contrast enhancement. So these three slides will show us what we are capable of characterizing some of these tumors. Notice the first panel. You see increased vascularity. It's somewhat heterogeneous, but tend to show persistent contrast enhancement. So early to come in, persistent contrast enhancement, mother-in-law sign. This is a hemangioma. Here is a lobulated, uniformly hypervascular on the arterial face images and kind of becomes hypo dense, or if it was an MR, it becomes hypo-intense to that of the adjacent liver. This is a focal nodular hyperplasia. You see an exophytic, heterogeneously enhancing hypervascular mass. There is a significant washout, and this patient had cirrhosis. So hemangioma, FNH, HCC. So if you get these things right, more likely that this lecture has been useful. Again, already mentioned some examples of metastasis. Again, whenever you see multiple hypoattenuating or heterogeneously hypervascular masses within the liver, something to consider. And what are some of the so-called bright tumors on T2 weighted images? The classic ones are the cysts, the mucinous cystic neoplasm, or hemangiomas. So these are the so-called bright tumors on T2 weighted images. And you can, as already shown, an example of bile duct hematomas, or even in this case of a peribiliary cyst, you can have multiple T2 weighted lesions. And another thing to just, instead of brushing all T2 hyperintense lesions as cysts, one should look for the post-contrast images, and this was a cystic liver metastasis in a patient with high-grade serous carcinoma. Again, on initial thought, maybe we are dealing with a complex cystic mass or somewhat with minimal wall irregularity and other things. So one could be kind of, forgiven if they thought it was some kind of a benign cystic lesion, but this was a patient with an nasopharyngeal carcinoma with associated PET CT that shows increased avidity, particularly in the periphery. So this was a metastasis. So although we think that we can diagnose and characterize many of these masses, sometimes you can have curveballs or leg spinners that we encounter not too uncommonly. And this is another case of, we couldn't really characterize just based on the imaging characteristics. This was somewhat of an intermediate signal intensity and kind of shows this peripheral rim enhancement, and it was not very clear. It showed some kind of a uniformly, not markedly echogenic, but somewhat moderately echogenic mass, and this was a case of a sclerosed hemangioma that we could establish the diagnosis based on biopsy and histopathological examination. And with that, I think I've shown you significant or a wide spectrum of mainly primary tumors and how we can diagnose some of these tumors. And I've discussed both the primary and the malignant flavors of primary liver tumors. One should be confident enough to diagnose the hemangiomas, the focal nodular hyperplasias, or hepatocellular adenomas in the correct clinical context, and obviously the cholangiocarcinomas and the hepatocellular carcinomas, again, in the context of chronic liver disease or cirrhosis. So with this, I'm happy to take any questions, and I'll stop sharing.
Thank you, Dr. Srinivas. Very lucid presentation. Question in the chat.
You have one question in the chat to Dr. Srinivas.
Okay. Let me see.
When do you suspect epithelioid hemangioendothelioma and HCC?
Yeah, I mean, again, I have examples of everything, but I didn't want to cause more confusion than is required. Particularly, those are diagnoses based on histopathological. Most of the times when we get these patients, they have already biopsied. So epithelioid hemangiotheliomas, again, heterogeneously enhancing hypervascular, multiple masses typically, and they are almost very similar to the hypervascular kind of metastatic that we encounter with neuroendocrine tumors. So this is a diagnosis typically based on histopathological examination. And same is the case with HCC and CCA, which is a hybrid tumor having both HCC and the cholangiocarcinoma component. One can potentially say that if you see kind of a mixed pattern, one can suspect this hybrid tumor. But to me, I tend to keep it simple and not necessarily raise the possibility unless the pathologists have the perfect pure proof for that. So I tend to not suspect something unless it is in the common categories of tumors. And typically these diagnoses have some management implications, particularly the epithelioid hemangioendothelioma. It's a sarcoma, so it's managed by the sarcoma clinical oncologists here, and clearly, these are some of the difficult diagnoses, poor prognosis. So I tend to leave the diagnosis for the pathologist. And again, hepatoblastoma, it's the second question. It's not my area of expertise. It's typically in the pediatric population. Again, I think you guys know more about hepatoblastoma than me.
Thank you, Srinivas. We have some gastroenterologists too on the panel. Dr. Gopi Srikanth is my colleague. Gopi has got something to ask or add.
No, sir, it's a good lecture.
Thank you.
So I think you have comprehensively covered everything, sir. It's very interesting lecture. So I have nothing to add, sir. Yeah.
Thank you. Thank you. So, I mean, basically, sometimes, it can be quite challenging, particularly if you don't have all the parts of the puzzle. we sometimes don't know the clinical context or the laboratory findings, especially the case in which there was a diffusely infiltrative HCC with microscopic fat. The AFP was through the roof, yet the pathologist probably didn't notice that, or they did not read the radiology report and just called it as steatosis. So as diagnosing clinicians, we need to keep in track of various parts of the puzzle before we actually make the right diagnosis. So sometimes we lack as well some of the information, and clearly, as treating clinicians, you guys have a global or bird's eye view of various abnormalities the patient has. So you're in a better position to treat them.
Yeah, I have a couple of questions, Srinivas, age-old questions. A
Yeah.
focal lesion detected at ultrasound, which imaging modality would you recommend? Do you want to do a CT or an MR for further characterization?
Yeah, I'm somewhat biased towards MR, just because one can potentially look for a microscopic fat. Even the macroscopic fat, even if it's a small amount, we can detect it. So which helps in my differential diagnosis. And also, I mean, again, in a non-cirrhotic liver. In a cirrhotic liver, to me, it's invariably, it's going to be something sinister. And even if a pre-existing hemangioma or FNH was present before the cirrhosis set in, it tends to shrink the good guys. Only the bad guys can grow. So in a cirrhotic liver, I tend to favor CT. In a non-cirrhotic, just for characterization, I tend to favor MR, just because it gives me some more information than what the CT can give.
Then the other question is always about whether a lesion detected with no typical features of a hemangioma, whether it's an atypical hemangioma or something else in a low clinical context of having a malignancy. So how do you deal with those atypical hemangiomas? What are any clues to them?
Yeah, atypical hemangiomas are atypical only for non-suspecting radiologists. Most CTs, good quality multi-phase CT and MRs can diagnose most hemangiomas, whether they have a little bit atypical finding, but for the most part, I have seen so-called typical findings just based on what I'm looking for. Particularly, I've seen so-called, hypodense lesions in the context of breast cancers, and we frequently get them. So, but if you notice that, if you have good quality multi-phase examinations, you will find that peripheral nodular enhancement at some point, this one that is isodense to the aorta. So for the most part, I think we are better with either CT, but particularly MR with the so-called atypical hemangiomas that we can characterize in a much more confident way.
Any experience with dual energy in characterizing or picking up lesions? Your experience?
I mean, I'm not a very big fan of dual energy per se, but to me, the classic post-contrast dynamic phase, multi-phase imaging characteristics, that gives me more information than, the so-called dual energy advantages. But per se, I'm not a very big, even for so-called, pancreatic cancers and other things with the iodine phase images only we can see. But again, if you see a ductal dilatation and either a hypo or isoattenuating mass, you're likely dealing with a adenocarcinoma. So people tend to tout that technology somewhat more. But
Yeah.
to me, for liver lesion characterization, I don't think it adds much.
So before I come to Gopi's question, you showed various types of HCC at histology. So how confident or how
No,
imaging
I mean,
is
I
being
don't.
able to characterize those types
Yeah,
at
I
imaging?
don't go into that space at all, partly because it's an evolving science. And second thing, it's, as already alluded to, it is morphomolecular. So it has both the histopathological component as well as sometimes the morphology, I mean, the genetic abnormalities associated with these tumors. So we are still not there. I mean, the same is the case with the hepatocellular adenomas. There are now at least 6 or 7 different kinds of flavors, histopathological flavors of adenomas. But for me, there are only 2 types, the steatotic and the non-steatotic type. So, I mean, I still recall, the pathologist may have, 10 different types for everything. But from an imaging standpoint, we may have 1 or 2 or maybe 3 at most. It's the same is the case with kidney tumors. The there are at least a dozen different kinds of kidney cancers, but we can only confidently say uh, clear cell, papillary, chromophobe at most, and many of them are beyond our characterization.
Yeah, true. Like we had a brilliant webinar you did a year or 2 years back about the renal cell tumors. About the same thing. I would
Yeah.
urge the delegates to go back to the KREST webinar series and do that. So one question from Gopi is, what is your choice for HCC screening in cirrhosis? Do you do ultrasound or do you do an abbreviated MR? Apart from the biomarkers.
Yeah, I mean, basically, ultrasound, to be honest with you, ultrasound is not big in either, the whole of United States or even in North America. I think in Canada, the contrast enhanced ultrasound is kind of big in some centers, but for the most part in United States, it's CT or MR. And obviously, MR, it's kind of a preferred unless you're dealing with a patient who cannot hold his breath, who has complications of cirrhosis and other things, where a quicker CT might solve the issue for this one. But unfortunately, I don't think, ultrasound, it's really big in Asian countries, but not so big here. And to me, it's really challenging to pick up cancers against a cirrhotic liver. So to me, I need some kind of contrast enhancement. If I'm not very familiar with the contrast enhanced ultrasounds, but again, you cannot do contrast enhanced ultrasound of the entire liver. You can probably focus on certain areas of the liver or certain lesions and do. But for me, in order to have a quick look at the entire liver for screening for HCC,
Yeah.
I think a CT or MR would be my way of going about it. Although I don't do ultrasound here, and ultrasound is not very big for screening in United States.
Yeah, I think true. What is that true is about contrast and ultrasound. If you find a focal lesion, probably could better characterize it at
Yes.
contrast and ultrasound, but you can't really use it as a screening for the entire
Yeah.
liver. Yeah.
I mean, that is my thing, that you need to look at the entire liver. And to me, I think MR is probably preferable. But again, I think if one goes by availability and quick throughput and other things, CT is equally valuable. That's what I find.
Yeah. This is the era of AI in imaging all over. So we had a conference in our hospital today and we had a lecture from Professor Sridhar another group about AI in radiology. So what is the take of AI in liver imaging? Any personal experience thoughts?
Not really. I mean, again, there are some scenarios where that might be helpful. One is probably in decreasing the amount of contrast, either with MR or with iodinated contrast with CT, that one can reduce the amount of contrast that we need. Particularly in neuroradiology, there are some excellent where the AI has drastically reduced the amount of contrast that we need for detection and characterization and localization of these tumors. So I think that's one thing. Second thing, AI will definitely decrease the times that we have currently for MR. I mean, now we are doing sub-second, imaging on CT. Speed is not necessarily something of an issue, but with MR, I think some of the sequences, and particularly patients who are dyspneic, who are short of breath, who pediatric patients. So clearly AI can either decrease the time that may be required for scanning and obtaining multiple sequences. Third scenario, which I think will help the radiologists in terms of a quick, if you are able to feed the images, let's say to an AI machine and tell, you know what, just pick all the hypervascular lesions for me and just mark them for me. And then subsequently, I go back and see, okay, this is a hemangioma, this is an FNH, this is what looks like a HCA or HCC. So it definitely cuts down on my time and improve productivity. So to me, improved throughput by faster scanning, decreasing contrast, and improve efficiency of radiologists. These are some things that I think may positively impact. But definitely when it comes to, the liver imaging, I think we cannot be replaced, at least till I retire.
Yeah. So there's another question for MR contrast preferred agent, the hepatobiliary or the extracellular. Which one do you use both, or how do you go about deciding?
Yeah, I mean, different institutions have different policies and kind of. I prefer the bread and butter extracellular agent for the first time you want to see anything in the liver. Because if you obtain, let's say, hepatobiliary right from the first study, what's my primary consideration or primary tumor that I'm going to see? It's either hemangioma, which can be kind of mislabeled as something else. We may call it as a metastasis if we don't know what it is. So if particularly the first time I want to characterize something, I prefer an extracellular agent. And once I know, let's say there is a toss-up between FNH and an adenoma, then probably a hepatobiliary agent will help me, although with some caveats. There are some adenomas such as the inflammatory or the beta-catenin that tend to show increased uptake even on that. So to me, I would prefer an extracellular agent. And in case of some of these challenging scenarios, I prefer the hepatobiliary. If the surgeons want for better localizations, they want to know where exactly the tumors are in the liver, I think hepatobiliary agent will provide excellent, they look like holes, all the metastases, so they can pick which ones they want to target and take it out. So our surgeons particularly are very aggressive here in terms of treating some of these widespread, what I look like as widespread untreatable cancers, but they will take them for surgery. So in that context of mapping out the various tumors before surgery, I think I prefer the hepatobiliary agents, even in the context of neuroendocrine tumor metastasis. It's helpful.
Nuclear medicine physicians, Kavita is here, Mother is here. Any role for your age-old RBC labeled studies, or especially in
think
hemangiomas?
Yeah, I will leave it to them.
We still get some
Do you
cases.
still use them, or you've given up on those?
We do get some atypical hemangiomas and there any. We do still do RBC blood.
Yeah, in the last 3 years, I've did one case of an atypical hemangioma blood pool RBC labeled study, which we found it useful in that instance. But maybe as Dr. Srinivas says, you should look at the CT and MR images in more detail to look for the arterial phase, nodular peripheral hyperenhancement. Maybe those would help.
Yeah, what happens is in many scenarios, we just obtain just portal venous phase images, and that's the only image that we have. So sometimes the non-contrast is equally helpful as the post-contrast images. So if one has an entire spectrum of multi-phase images, I think we can identify many of the atypical findings of the common lesions.
Any other comments or questions from the other delegates? Yeah, thank you so much, Dr. Srinivas Prasad, for having readily agreed the short notice, acceding to Kavita's request. Thank you so much. It's a wonderful lecture, and hope to see you in January 26 in person at the wonderful conference we're hosting in Hyderabad, the Radiology Annual Conference. So the next webinar would be on AI in medical imaging. That's emerging technologies and AI in medical imaging, a 2026 perspective and beyond. Another NIMS alumni, Dr. Mahankali Srikanth, would be speaking about it on 12th July. Hope to see you all, and I think that will clarify most of the questions and apprehensions about AI. See you then. With the leave of Kavita and all, and Dr. Srinivas, you take leave. Hope to see you again soon sometime.
Thank you, Dr.
So I'll be doing Shirshasana during that lecture. Happy International Yoga Day again.
Yeah, thank you so much. Happy day.
Thank you.
Thank you. Bye-bye. Good night.
Thank you, Ishwar. Good night.